بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. آمين يا رب العالمين. My short talk today is about intracranial hemorrhage. Intracranial hemorrhage is referred to any bleeding within the intracranial vault, and it is include the brain parenchyma and surrounding meningeal spaces. If it is intraparenchymal, we call it intracerebral. If it is intraaxial, can be intracerebral or intraparenchymal, or can be extraaxial and can be in the epidural space, subdural space, and subarachnoid space. The patient presented with acute onset with symptoms of weakness, numbness, paralysis, severe headache, loss of consciousness, lethargy, and coma. What are the causes of intracranial hemorrhage? Head trauma, one of the causes. Hypertension, also one of the causes. Thrombosis in the arteries, one of the causes, or any disease of the arteries like vasculitis can cause intracranial hemorrhage. Rupture aneurysm, one or another causes, and amyloid angiopathy, and AVM, arteriovenous malformation, treatment with anticoagulant therapy, a bleeding tumor like metastasis, smoking, excessive alcohol, cocaine, condition related to pregnancy or childbirth like eclampsia, postpartum vasculopathy, neonatal intraventricular hemorrhage. CT, non-contrast CT, is the most rapid and readily available tool for diagnosis of intracranial hemorrhage. And it is a provide definite diagnosis and also show basic characteristic of the hematoma, like location and extension of the interventricular system and surrounding edema and midline shift. CT angiogram is gaining increasing acceptance as diagnostic tool in the acute setting, and it is the most widely available non-invasive technique for ruling vascular abnormalities as secondary causes of intracranial hemorrhage. The risk of acute nephropathy, if any, is likely quite low. Up to 15% of patients with intracranial hemorrhage shows underlying vascular etiology on CT angiography. Contrast extravasation seen on CT angiography images known as spot sign. It is thought to represent ongoing bleeding and appears on the mark those patients at highest risk of hematoma expansion and poor outcome and mortality. Here, this patient with intracerebral hematoma in the intrathalamic or the thalamic region and extended to the intraventricular to ventricular system, occipital horn. With CT angiogram, the patient has extravasation of the blood indicating active bleeding. MRI with angiogram for better evaluation for non-hypertensive hemorrhage to rule out underlying vascular malformation. In this discussion, I will discuss and concentrate on the CT findings. In another talk, I will discuss the MRI findings of intracranial hemorrhage. Broad classification of intracranial hemorrhage can be classified to intraaxial, extraaxial, intraparenchymal hemorrhage bleeding within the brain parenchyma, intraparenchymal further classified as basal ganglia and lobar bleeding. Basal ganglia are most common than the lobar bleeding, usually hypertensive patient. Lobar bleeding is this likely to be hypertensive, and we should look for other causes like amyloid angiopathy or tumors, etc. Here, this patient with hypertensive hypertension patient, and there is a bleeding in the left thalamus extended to the left lateral ventricle. Here, another hypertensive patient with intraparenchymal bleeding in the left thalamic region. Here, in the left basal ganglia, in the right basal ganglia with patient with hypertensive hemorrhage. Another patient with hypertension in the right bottom hemorrhage in non-contrast CT scan, and the patient has also has calcification in the basal ganglia and the binary gland. Here, two patients with the right cerebellar hemorrhage due to hypertension with mass effect on the fourth ventricle. Here, the same patient on the second one with right cerebellar hemorrhage on T2 weighted imaging MRI. The CT scan can, if it is hyperacute, within less than 12 hours, presented up to 2 days, presented hyperdense lesion. Early subacute to 2 to 7 days, it is hyperdense lesion, and late subacute, it is isodense lesion up to 1 month, 8 days to 1 month, and in a chronic case, it will be hypodense lesion. Here, another patient with acute intraparenchymal bleeding in the left thalamic region extended to the ventricular system. And this patient in warfarin and has a large bleeding in the right occipital region and subdural space and extended to ventricular system with mass effect. This patient has bleeding on the right occipital region due to amyloid angiopathy, and after 3 months, the bleeding is resolved and developed another bleeding on the left occipital region. Here, another patient with also cerebral proliferative angiopathy on the bleeding here on the MRI T1 and T2. Here, this is different patient with cavernous angioma on the CT scan. on the right frontal, left frontal, and on the right side here. Here, another patient with AVM, and we have calcification in the left occipital region, calcified philobelith, and numerous hyperattenuated vascular channel. And on MRI, there is a large occipital AVM in this sagittal view. This is the MRI. This is the angiogram of this patient with AVM. Here, another patient with meningioma with the bleeding in the subdural space and in the right front operator region, and with mass effect. Another patient with the tumor, neuroectodermal tumor, presented with the bleeding and non-contrast CT scan. And this is the tumor after resolving of the hematoma. Extraaxial hemorrhage, the bleeding occur in the skull, within the skull, but outside the brain tissue, can be in the epidural space, like epidural hematoma, subdural space, as in the subdural hematoma, and in the subarachnoid space. Epidural hematoma, 98% of cases associated with fracture, and it is post-traumatic, involve the vessels in the temporoparietal region, mostly due to middle meningeal artery. If it is in the frontal, it is ethmoidal artery. If it is in the occipital, transverse or sigmoid sinus, and in the vertex, in the superior sagittal sinus. Lucid interval followed by unconsciousness. Shape of the collection is banana shape or biconvex or lentiform shape. Surface area of hematoma is smaller compared to subdural. Since limited by dural attachment at suture, never cross suture line, may cross the midline falx in the frontal region as it is outside the dura. Here, patient with fracture and subgaleal hematoma, and the patient has large epidural hematoma, as we see air bubbles due to laceration of the tissue here. Subdural hematoma, it is traumatic, as can be traumatic as well non-traumatic. It is involved the bridging veins, a gradually increased headache and confusion. Shape of collection is concave or crescent shape, looks like banana, and the epidural hematoma, looks like lemon shape. Surface area of hematoma larger than the epidural because extend posteriorly over the cerebral convexities. It is across the suture line, but never across the midline, may extend along the interhemispheric fissure and the tentorium. As we see here, large subdural hematoma with midline shift on the left side. Another patient with hypodense subdural hematoma with midline shift. Subarachnoid hemorrhage, besides from head trauma, may occur spontaneously, usually from a ruptured cerebral aneurysm. Symptoms of subarachnoid hemorrhage include severe headache with rapid onset, thunderclap headache, vomiting, confusion, or lowered level of consciousness, and sometimes seizures. CT is the modality of choice. seen as hyperdensity in the region of cortical sulci, basal cistern, and sylvian fissure, depending on the amount of bleeding. If CT is normal, to be followed with MRI FLAIR and MRI angiogram, confirmation by lumbar puncture. Here, patient with subarachnoid hemorrhage appear hyperdense in the around the bones and the suprasellar cistern and sylvian fissure. Here, another patient with subarachnoid hemorrhage in the suprasellar cistern and ambient cistern, in the peduncular cistern, and in the sylvian fissure, more on the left side. And we see here looks like a soft tissue density surrounding by blood, and this is the CT angiogram. Approved patient has posterior communicating artery aneurysm. Thank you for listening and hoping to see you soon in another talk. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.